Okay, I will click go live.
Thank you.
Okay, you're live.
Hi, everybody. Welcome to the August meeting of the Kansas COVID Vaccine Equity Task Force. So nice to see everybody and welcome to any new members. So I have a couple of announcements. So COVID operates in compliance with the Kansas Open Meetings Act. This meeting is being recorded and live streamed on KDHE's YouTube channel. Please mute yourselves when not speaking to prevent audio interference. So my name is Jimena Garcia. I am the Governor's Senior Advisor for Vaccine Equity, and I'm going to be leading this discussion today together with my colleagues from KUMC and also KDHE. And I want to just quickly go over like our agenda with, so as usual, we're going to start with a moment for any quick introductions from new members, and then I'm going to walk you through the most recent COVID vaccine data. And then after that, we're going to move right into our panel discussion. So last month, Dr. Glenn was here with us sharing his knowledge about how the historical roots of medicine really contribute to distrust in medicine today. And he is gracious enough to have agreed to come back today to participate in a panel discussion. So we're going to look prospectively at how all of us can be working to repair and improve mistrust of government and medicine. And after that, I'm going to open the floor for a few minutes to hear from anybody who wants to share information about an upcoming event or an announcement. So why don't we start by seeing if there's anybody new today to have quick introductions. It looks like really there's not anybody new. Okay. I might pause for a second. Do you all think we should press forward?
Yeah, it might be good to pause.
Okay.
I have gotten a few more emails asking
Okay.
about COVID.
Okay.
And we're sending out the link furiously.
Okay.
I'm not sure if there's something happening. Yeah. Matt, any thoughts on your end? I cannot send I can't send an update to the invite just to remind people, but I'm not sure what my options are as not the meeting organizer.
I can try to just resend it to the people that are on the original one and see if that helps.
I will also get on and re-forward it to the folks who we connected with since the last session.
You know, I'm looking at the invite and I wonder if there was an issue with the invite.
Should we pause the recording?
Welcome, Peggy. It's Courtney. Miss Peggy, because you are somebody who had some struggles getting on via the link, but now made it, can you tell us what you saw and the challenges you had? I'm not able to hear anything. Can anybody else hear Miss Peggy? No? Okay. We do have some people trickling in, so this is hopeful.
Hi, Peggy.
Hello.
Yay, we can see you and hear you. Oh, yay, this is.
Okay.
Hi, everybody. For those just joining, we're just pausing a minute because it seemed like there was something funny with the link that made it hard to get on. We could take this minute actually while we're waiting to do quick introductions from new members. I feel like there are a couple of people that are here for the first time or not regular. So I would open the floor to whoever's new to share your name, your organization, and then we always do what is your glow? That's 5 words or less about something that is so interesting to you that you could talk about it at length anywhere. So for whoever would like to start, I'll open the floor.
I can start. I know many of you. Hi, Vicky. We used to see each other like all the time. It was crazy. We had lunch together, but we haven't seen each other for a while. Anyway, my name is Lucia. I am an associate director for social determinants of health and the maternal program for United Healthcare, one of the MCOs in the state of Kansas. And then you say something, glow, right? Something that is for me like super, that I like to talk about it a lot.
Yes.
I love to talk about the connection between our mind, heart, and body. That's something that I like to read about and study and talk to people about that.
Wonderful. Thank you. Denise, would you like to introduce yourself?
Sure. Hi, everyone. Yes, my name is Denise Romero, and I am a community health worker, promotora de salud, with Salud Más Bienestar. We facilitate out of Evergreen Resource Center and Library here in Wichita on the North End, to be specific. And something that I always talk about and that helps my mind and my body are my kids and my pets. I have 2 kitties, and I just got a little puppy. She's a blue healer, and right now it's all about how they're getting along. So I love talking about that.
That's very cool. Thank you. Anna, would you like to go next?
Yes, hi guys. My name is Ana Lopez. I work for the city of Wichita here in Wichita, and I work closely with Denise Romero because we office out of the same facility, the Evergreen Community Center and Library in the north end of Wichita. We serve a large population of Hispanics as well as residents in general. We live in a very multicultural area of the city. And what was the question? Was it 5?
Just 5 words or less, something that you're very passionate about that is easy to talk about wherever you are, that you could go on and on.
Okay, so one of the things is I always like to talk about what's going on in the community. So I like to connect people with things that are happening. I also like to talk a lot about my kids and my family and what's going on, what they're doing, where they're at. So it feels like it makes you connect with other people.
Thank you. That's great. And Laura?
I apologize, I'm not on video today. I'm sick, being sick 2 weeks now.
I'm sorry.
Started feeling a little human today. So I said I'm not going to miss these meetings. It's going to be a good leeway into starting to get back into the work rhythm again. My name is Laura Canelos. I work for United Healthcare Community Plan of Kansas with Lucia. We're one of the 3 MCOs for CanCare. I do community outreach for the health plan, and really looking forward to learning from you all and finding more ways of collaborating. And something I was struggling finding like one topic that I'm passionate to talk about, because I'm usually jumping from topic to topic. And I like talking about whatever is kind of on my mind at that moment. Things that are important are my family, of course, and community, and ways in which we can build bridges between organizations, agencies, government, and community, so we can make life better for all. Thank you.
Thank you. And I'm purposely skipping the panelists because they're going to introduce themselves during the panel discussion, if that's okay.
Sorry. Hi, everyone. We have had an unusual technical glitch with the invite and the access. Because we have our experts on and several COVET members, our thoughts are that we plan to proceed with the agenda. We will record this and distribute the recording and encourage the full COVET membership to review, and then also we'll plan to devote a lot of the next meeting with their reflections and discussion about that. So my apologies for this. It was unexpected, but I think if we can proceed with the agenda, I think that's probably the best approach at this time.
I appreciate it, Vicki. Yeah, and thank you to all of you for your patience. Okay, well, why don't I start with a quick review of the vaccine data. So if we could have the first slide. Thank you. Perfect. Okay. Okay, so I just want to walk through the most recent COVID vaccine rates in Kansas and kind of just call out the stuff that seems important to me now. So this first slide shows vaccine and booster rates by age. So the first column of the slide shows that almost 56% of Kansans have received their primary series. So for most people, that's 2 doses of vaccine. And then every age group is eligible for a booster except for under 5s. Yet the total booster rate is only 50% of those eligible in Kansas have received a booster. And I just want to call out, and I feel like, I'm sorry if I keep repeating this, but the booster at this point is really the most important thing you can do to protect yourself against severe illness and death from COVID. So it would be really nice to get those numbers up. So then if you move to the right on the slide, you see vaccine rate decreasing by age. So the first column has people over 65, and you can see that they have the highest vaccination rate. So almost 85% have completed the full series, and of those, 73% are boosted. So yay to people over 65 in Kansas. And then as you move to the right, you see that as the age goes down, the rates of vaccine and boosters go down. And on the far right is tender age, which is the newest vaccine. So it's for people under 5. And in Kansas, we have 4.3% of kids under 5 vaccinated. Next slide, please. Actually, we're going to skip the next one. Yeah, go to the next one. Okay, and so this is vaccine rates for children broken down by race and ethnicity. And this data counts kids who have received at least 1 dose of vaccine. So there's really been minimal change in the rate over the past 3 months. So the rate of vaccination for all kids in Kansas is almost 32%. And the rate of vaccine for white kids is 26%, Black African-American kids, 19%, Asian kids, 40%, Indigenous Kansans between 8 and 15%, and for Latino kids, it's 30%. Next slide. I wanted to take a moment to acknowledge that our vaccine data at this time for Indigenous Kansans is not precise. So the issue is that we have data reported to the state system through WebIZ, but this data is not considered complete because tribal communities don't have to report the data necessarily. And then we also have the data that we get from IHS, which is actually considered to be an overcount because tribal communities have been very generous with their vaccine. And so that data includes non-tribal members who are in surrounding communities, and so therefore that rate makes it's an overestimate. So and a little note that we are working to improve our data. We have a subcommittee of partners that are working with IHS EPIs, KDHE EPIs, and trying to come up with a way to have more precise data going forward. So next slide. Okay, so here we have vaccination data broken down by race and ethnicity in adults. There's been even less of an increase in the last 3 months of the adult vaccination rate, but the overall rates of adults receiving 1 dose of COVID vaccine is 74% for the state. For white Kansans, it's 56%, Black Kansans, 50%, Asian Kansans, 62%, Indigenous Kansans between 25 and 64%, and Latino Kansans, it's at 72%. Next slide. And this is, again, an explanation of why we're not exactly positive, but we know that the vaccination rate lies somewhere in between for Indigenous Kansans. So you could take down the slides if you don't mind, Vicki. So in a moment, I'm going to pass the floor to my colleague, Courtney Hayden, who's going to moderate the panel discussion today. So our panelists are Dr. Jason Glenn, who is a professor of history and philosophy of medicine at the University of Kansas Medical Center. We have Troy Spain, who is a co-founder of the Kansas Civic Engagement Table, and Peggy Fox, who is the president of the Wichita Black Nurses Association. So the thought process behind the discussion today is to build on what we discussed at the last meeting. And if you were not at the last meeting, that is available. There's a link that we can provide. It's recorded and it doesn't disqualify any conversation today, but the thought was sort of, that was a retrospective look at the historical roots of mistrust in the medical system created really by the way the medical system worked. And now we want to shift and look prospectively. So sort of like, where are we now with mistrust? And what steps can we take going forward to be mindful in our work of how to do this, and also how to be good allies to try to start to earn trust back. So we're going to ask the panel to introduce themselves, and then we have a set of questions that we shared earlier with them that we're going to go through. And if time allows at the end, we can ask for questions from the group, but we'd like to have the questions written in the chat. So with that, I'll pass the floor to Courtney.
Hi, everybody. Thanks for your patience with our technical adventures. I feel like it's unavoidable. We are not experts despite having been remote for a couple of years now. So a couple of thoughts before we jump in. I want to say that I encourage you to turn on or off your camera as needed if you need the space to process some of what we're discussing. Stand up, stretch, grab a glass of water, and maybe have a notebook handy. So if thoughts come to your mind, experiences come to your mind, Dr. Jimena and I are available to you. I think that we know everyone to some extent individually. You can feel free to email us or find a trusted friend, colleague, or family member to discuss what comes up in this room. I know that after our last session, I was moved deeply. I spent some time debriefing with Dr. Jimena. So this interest in your sort of self-care through the process is valuable to us. So we're working through this with you. With that, I would like to hand over for introductions. If I can start with Dr. Glenn.
Sure, and forgive my voice. I'm actually recovering from COVID. It finally got me. But I am Jason Glenn. I am Associate Professor in the Department of History and Philosophy of Medicine at KU, and I do generally work on health inequities, particularly those related to mass incarceration. Thank you.
Thank you. Ms. Peggy, would you like to go next?
I mute myself here. Thank you, Courtney. My name is Peggy Jones Fox, and I'm the president of the Wichita Black Nurses Association. Been in this position since January. Joined this organization in 2021 and have worked feverishly with the other members of the organization, having mobile vaccine clinics to vaccinate as many Wichitans and the surrounding areas as we can, hosting workshops and educational meetings to try and encourage continuing with protecting individuals and families from COVID and educating them on that. So that's kind of been my mission and ministry here the last 18 months or so. History, just for background, I'm a nurse, an infertility nurse, and last 10 years with higher education with the University of Phoenix as a regional director, teaching for the university and also doing administrative work. Thank you, Courtney.
Thank you, Ms. Peggy. And Mr. Troy.
Hey everyone, my name is Troy Spain. I'm the Executive Director of the Kansas Civic Engagement Table. The work that we do at the table is really around data management, IT work, and support for canvassing operations in the state. Part of that, we expanded into the COVID relief effort, trying to get vaccines into communities as fast as possible. My background is in HIV, LGBTQ relations I went to Kansas State University for a management degree there, worked for Walgreens for 15 years doing outreach work there, and then went forward at the University of Colorado Boulder with a transforming communities specialization to learn how to deeply invest in communities and make change from there. I will state that I am part of the LGBT community. It's a thing that is important to give context to sort of the work that I'm going to be talking about later on. So I will also make that little statement there. I'm very excited to have this conversation and move forward. So thank you, Courtney, for having us.
Thank you, Troy. What a perfect lead in. You couldn't have helped me more. I just want to make a general statement, which is that we understand that people identify in many ways. We acknowledge that everyone in this room has an identity that brings a unique perspective to this conversation. And we are making an active effort to make space for you and your experience. With that said, I have a series of questions. Some of these questions I may direct to one person to begin with, to the panel as a whole. If you are a panelist and you feel like, you know what, I really want to throw something in there and the question wasn't directed to you, do not be shy to do so. Maybe throw up a hand so that I'm not rude and speaking over you by mistake. The first question I have, and I'll give you a heads up here, Dr. Glenn, it's for you. I'd like to begin by discussing how you observe the roots of historical mistrust impacting the current experience of the communities that you engage with.
Thank you, and that's a good question, Courtney. You know, when we ask members of the community directly why they harbor mistrust, you know, a lot of the reasons that they may give are not always very specific, or at least not specific enough to the standards that we would have as historians, right? But what we find is that a combination of sort of these national stories that collect headlines in addition to the normal everyday, you know, issues of disrespect or issues of treating people like they don't know their own bodies, that they can't be experts in when something is wrong with themselves. Those normal everyday mistreatments trickle down in communities and, you know, become inherited, you know, in ways where people can't always even give you specifics, right? But it exists as a general sort of knowledge or wisdom that you need to be careful when you enter into medical spaces, and only do so, you know, if it's kind of a dire emergency kind of thing. And so sometimes that can be hard to counter, particularly when you realize that there's good reason that people feel this way, right? And rather than us going to community members and trying to necessarily convince them otherwise, I feel it's much more incumbent upon the medical profession to take a hard look at ourselves and see what we've done to earn this mistrust, and therefore see what kind of actions we need to take to correct it.
Thank you. Thank you, Dr. Glenn. Miss Peggy, I saw you nodding, and I'd like to give you a chance if you'd like to add anything.
Well, thank you, Courtney. And Dr. Glenn, I'll piggyback what you just said excellently. In preparation for this, when Dr. Garcia asked if I could participate in this, I kind of hit panic button at first. I'm like, what? I don't know if I know enough to do this, but I have my own experiences and I have information that I can offer up. And one of the things that I was thinking about with that first question, Courtney, or exactly what Dr. Glenn said, was I was looking up a few examples of that continues to invite the mistrust that we have in the Black communities and other communities that people have with trusting healthcare providers because of very negative experiences. And just the two that I want to quickly mention was the Black doctor that died from COVID-19 after she posted a video from her hospital bed saying she was being mistreated and that she wasn't being heard. They were listening, but they weren't hearing and actively considering what she said to be true, because she was saying she was still in pain, having difficulty breathing. And I'm sure you guys all remember hearing that. That was in 2020, and she was a physician. Dr. Susan Moore, Black physician in Indianapolis, died after she felt like she was being mistreated because of her race, just not being heard. So when others hear that, that just solidifies that for healthcare providers, is that, yeah, we're not to be trusted because they don't listen to us. And the other one that I wanted to mention was, it comes in that same category of when Serena Williams had her baby. And she has, and we weren't aware of this, but she has a history of blood clots. She takes the blood thinner, she takes heparin on a regular basis, but she went off of it, I'm sure as advised by a doctor, to have her baby. And so being off of the medication, she had, right after delivery in that 36-hour window, she had clots develop in her lungs. And so she was trying to tell them being healthcare providers, the nurses and physicians, that she needed a heparin drip and she needed a CT scan. Well, they really didn't hear her for a little bit. And again, hearing those stories just puts us at a disadvantage for trying to gain trust in our environment. So I just wanted to share those two examples of why this continues to be a problem. Thank you, Courtney.
Thank you. And you are absolutely, this is a common theme with panelists where people will send an email back and say, are you sure? We're sure. And we're very, very grateful to have you. I would like to give Troy a chance to chime in on this one as well.
Sure. Thanks, Courtney. I first want to acknowledge when you said you were making space for identities, I think it's really important to, especially from the LGBTQ perspective, to give some space for those hidden identities too. So in the queer world, we are not outed necessarily by our belonging to that community. Some of us choose to express in ways, some of us have no choice and express in ways that are obvious to others, but a lot of us take time to come out and to have ourselves known in true form to folks. And because of that, those identities may exist around you and not even be part of your understanding of what those people are experiencing. I think it's also a very similar thing to hidden illnesses. Depending on levels of disabilities and things, there are people with hidden illnesses that are in the same boat, where if they don't tell you and express what their disability or illness is, you may not know that they're part of that community while you're speaking. It is a place of privilege at times for those of us that live in that space where we can pass. So it is a different experience than those with skin color that is not white, right? That is something that marks them in a way that makes them othered pretty instantly in a room. Some of us have to make that leap, which is difficult at times, but also a totally different experience, and one that is probably similarly difficult in totally different ways. So I wanted to just make sure we made some space for that spot too. Around the question that you'd asked, we didn't give a ton of history on other groups. Dr. Glenn did a terrific job working through the African-American community last time. There are some deep-seated historical LGBTQ issues and mistrusts too. In the, just in modern times, right? I was born in 1981. I lived through the entire AIDS crisis, basically from start to finish. As we developed treatment, as we developed potential cure at this point, right? And as we sort of progressed through that and that whole length of history, the same folks that are in charge now, heading the CDC, Dr. Anthony Fauci, and these folks are the exact same people that were in charge during that crisis nationwide, which we hear a lot of, well, we didn't trust them then, do we trust them now, kinds of comments in the queer community. And I think it's really important to remember that, like, we are living through sort of the modern pieces of this as well, right? Like, there's deep-seated historical LGBTQ, oppression and things, but we're also living through like lived experience, like those of us that lost an entire generation of our folk to AIDS, and then see the same leaders in those positions. And so trust is one of those things that we have to earn. And it's something that I think the CDC did not sort of step into that space and do that proactively. And they're trying to, even now with monkeypox, trying to be more conscious of that. And I think that's why the verbiage and things that we're seeing are very different coming out of that. And I think that's really great, but it does lead back to a question of, like, if it's the same face making the same sorts of statements, like, how do I trust that messaging? So that's it. Thanks.
That was great insight. Thank you. And I know that I have sort of my notebook next to me. And so one of the changes that I just made is when we make space, I'm going to include the words visible and invisible. So I deeply appreciate that. Okay. So the goal of that first question was sort of so that whether you were hearing from somebody with an identity that you can relate to or not, you had a little taste of the fact that our conversation last month continues to relate on a really daily and visceral level for many members of many communities. And the next question, I want to start to get a little bit tactile, something that we can really touch and feel, to look at how we can be helpful, strategic, or successful. So what you have observed in your practice, in your work, that's been helpful, strategic, or successful for helping people to feel safe and supported when accessing healthcare. And I'm going to take a risk, but I'd like to say any panelist who wants to chime in on this, you are welcome to do so.
I don't mind starting things off. I think it's really about intellectual honesty and the intellectual honesty that we bring to our encounters with patients, with members of the community, with people seeking healthcare in any capacity. And that intellectual honesty that you can bring about the history of how we got here is really what can enable you to position yourself and be recognized as an ally in that struggle or not, right? It doesn't have to be the first thing that comes up in any patient encounter, right? Like, ooh, I know you've had this history of racism, I'm here to help. But it's really about not shying away, like when you recognize that there may be difficulties in developing rapport. That you take the extra time first to just listen, and then to very directly sort of identify yourself as an ally in someone trying to correct that history and make repair. That goes a long way.
Thank you, Dr. Glenn. Ms. Peggy, sorry, go ahead, Troy.
I would say, I think one of the important things is to let folks define their barriers for themselves, right? Like, It's really easy from an institutional perspective to try and define the problem before you walk into a meeting and have the agenda ahead of time and want to be very formal, but making sure that you allow community members to define what that barrier is for them is really important. A lot of times we talk about like being gay or being Black or being a woman are barriers, right? But that's not true, right? The real barriers are the patriarchy, right? The real barrier is homophobia. The real barrier is racism. And if you're going in and you're talking about, well, what are the barriers because you're this? It can be really difficult for someone to have a conversation because that automatically puts them in a position where they're defending their identity. Where if you define the problem, or you let them define the problem that they're facing, you can then let their identity be something they can add to the conversation, which I think is really important.
Thank you. I just want to take 1 second to pause and say this is an incredible group. And there is never a time when I'm in the room with any of our panelists and I'm not learning and taking notes myself. Miss Peggy, I do know that you have this background of being a clinician. You're providing direct service in the pandemic through vaccine. So I'm interested in your thoughts on this as well.
Thank you, Courtney. One of the strategies and that I use just in general with healthcare and working in mission and ministry with others is just reflective listening and developing, even for just 30 seconds or a minute, some kind of relationship before you start deviling into, the real nitty gritty with their healthcare concerns. Because some healthcare concerns can be difficult to talk about, embarrassing. They're giving you information about their personal bodies and experiences, and you want to respect that space that you're providing for them to share that with you. So just even opening with, hello, how's your day going? Just something in general where you could present yourself to be there for them. And this is about them and not about me getting in and out, giving you a shot and getting you on down to the next booth or whatever. But Jake, just taking a few minutes just to have a conversation with them to they can get a feel on you and you can get a feel on them and just say, okay, you and I are going to be talking about your health care or something, or I'm going to be administering an injection, or in my case, a lot of times doing exams with a transvaginal ultrasound or a pap smear or something like that. I mean, getting real personal. So it's important to provide that connection before you enter into that personal conversation or physical space with them. So I think the communication is reflective of, I'm here to serve you and want to show you that I'm here to listen and hear what you say and work from that. And as Troy just said, not to come in with my agenda or the agenda of my organization or administration, but I'm here to hear what you need from me and how can I facilitate that. Thank you, Courtney.
Thank you. That was fantastic. The thought that was in my mind listening to everyone was it takes work to advance dignity, right? So we can't assume that this is inherent or pre-built into our system, but that it really takes an active personal effort. Dr. Jimena and I always say, you don't know you're blind to equity until you know you're blind to equity. So to really be looking and educating and moving forward. Thank you all. So we've started this discussion sort of at that individual one-to-one, how do we make a patient comfortable? And I want to zoom a little bit higher and say, how can people in positions of influence, and we may be talking about policy or high level in healthcare administration or in public health, or any of those ways that you hear that word influence, whatever that means to you, because we know that influence in every community is unique. How can those folks support progress on equity and justice as it relates to this conversation? And I'm going to leave, again, I'm just going to leave it open. I think broadly, everyone has been bringing great insight.
What comes to mind for me is bringing people along with you. One of the things that we often talk about is making space for folks and letting them talk about their experiences and then using that to inform your decisions. But another important part of that is to bring them along with you as well. We get into Walgreens was a perfect sort of background, but when I was there, a lot of the folks that were in upper leadership were white. And part of the thing that we tried to do was reach out and train folks into those places, not just ask what would an African American or someone who is LGBTQ or who was of another group, what would they, what would do better with them? But part of it is teaching those folks the skill set that you have, letting them into those meetings, and then helping them kind of grow into that power and take their space.
I would add to that, sort of as an organization, not being afraid to really suss out what's going on in your organization and not being afraid to measure the problem. Because oftentimes we find leadership, they don't particularly want to know when there are systemic problems within their organization, because then there's the onus to fix those systemic problems. And to piggyback off what Troy said, you do need folks from outside that organization, oftentimes as fully empowered collaborators, sometimes to do that self-reflective work and tell you about yourself, right? And when I say fully empowered, I'm not just talking about one or two representatives in a room full of very high-powered senior people who feel like they have, way too little time to actually be there and listen to what these folks have to say. But a diverse, widely cast net of folks from the community who can give you a variety of perspectives that help your organization see where it's failing.
Thank you. Miss Peggy, did you have anything you wanted to add to this? I believe you're on mute. If you're
Unmute my mic here. When our disparities go up, life expectancies go down. And I think that that's an important statement in terms of when you're looking at people with influence. I think it's that they need to understand that raising the bottom also raises the top. We can't leave the healthcare of people that may be unemployed, underemployed, uneducated, all the unders and information, all of those kinds of things that you might look at when people are making poor healthcare decisions. It's not just that. We're looking at all the things that impact the health of a community. So making sure that folks that have influence understand those disparities and also those variables and how that impacts all of us, so that the right policies and procedures and resources are made available. Getting those people in that mindset will help raise the bottom and help make those decisions that we need to support the progress to move the ball forward. Thank you.
Thank you. Thank you so much. I'm gonna quote, because I don't have a better word, from the chat. And John Ella just said powerful with a couple of exclamation marks. And that's going to be the extent of my feedback on your answers to this question. I do want to, oh, yes.
This is Virgil Watson.
Hello, sir.
And I have my camera off because I didn't get prepared for this. It kind of popped up on my calendar and then I jumped on. But you have to lead by example. And I'll take our church organization as one example. Our pastor was one of the first ones to get the vaccine. Once he did that, it kind of opened up the floodgates, the rest of our congregation. And it just gave an example that I think it's safe because I'm taking it. I think it will help us because I'm willing to take it. He's an attorney, and so he researches all of the data and information to make sure that it is safe for him and his family. Once he reached that point, I had asked him, can we have vaccine clinics at our church? And he said, yes, because I've already done my own research and I want to be one of your first individuals to get the vaccine. And it was in short supply early on. And so he invited friends and associates from Wichita to come to our city and to get the vaccine shot because they couldn't get it in Wichita. But simply because he was willing to step up and be the first in line, helped the rest of our congregation to feel more comfortable with the vaccine. And I think from a larger perspective, when politicians and people in public health want to reach out to us, if we only see them once every 5 years and they're never coming around on a regular basis to assess how we're doing, how they could help, and it's difficult to get into the public health office to seek out information and to have questions answered, to access vaccine, then I am going to distrust and go through that process in order to get health care. And from a more focused standpoint, if I go to my doctor's office and I have to wait for an hour and a half, is it just me? Or does this happen to everybody? And after a while, I start to seek other avenues to get health care simply because I want to be treated like I'm an important customer to that organization. Just a few personal highlights.
Thank you. Thank you, Mr. Virgil. And I would highlight that you are in your own right a person of influence. So we appreciate hearing from you on this.
And can I say one more thing?
Yes, sir.
Out of this group, this task force, someone asked a question one time of how influential are you really being? And so we're conducting a survey of our congregation, see if we did actually impact, and those individuals that are still hesitant, why are they still hesitant? What can we do to help them? How can we help keep them safe from COVID or any other health concerns they might have? And I'm working with Ian Knight, and he and I are going to, we've gotten all the surveys taken now. He's analyzing the data, and next Tuesday, we'll be going over that. So I'm anxious to see, he hasn't given me any insight as to whether it's good, bad, or indifferent. So I'm anxious to see how we did. And if we did fail, how do we overcome that failure and become more influential to our congregation? Because we say we are, and that we have influence. Now it's time to measure up and see if we can prove that.
Yes, sir. That's fantastic. Thank you. And that's what we want. We want this group to be a group that leads to direct action, and a group that you feel like you can utilize the resources or connections herein to do so. So we're excited to hear about that in the future. It is almost 12:50. We did have a plan to take the call offline to allow that last 10 minutes for discussion. I'm gonna ask the panelists a challenging question. So I'm gonna pose a question, and I would say if you can give the answer 30 seconds or less, it's a hard question, then we will go off of live stream and we can continue that discussion at breath. But I do want to give us a few minutes where we aren't live streaming to really dive into some of this content in a space that we know, hi YouTube, that we won't be on YouTube in the future. So the question relates to allyship, and particularly cross intersectional allyship. So I'm wondering what techniques and actions have been successful for our panelists in being an ally to communities outside of their own. And how can people be a good ally to your community? And again, I'm going to leave this open to the group. Like we said, sort of 30 seconds ish of an answer, and then to our technical folks on the line. Once all three panelists have answered, we can take ourselves off the live stream.
Very quickly, I would just say first, humility and listening. Approach the other communities with the humility to assume that you don't know, even if you think you are well versed, well read, or well knowledgeable about some of the struggles or hardships those other communities may face. Always approach, from a space of humility, and ready to do more listening than talking.
That was a fantastic summary. Thank you.
Courtney, I'll chime in with Dr. Glenn and say one of the strategies and methods that we employ for the Wichita Black nurses is we try to identify a trusted leader in that community to work with and help us to understand that the dynamics of that particular community, because even though we are in a, we're looking at the Wichita community, we all live in communities that have their own culture and own identity. And so we try to find someone that lives in that particular community, that's a voice for that community, and work with them to be able to integrate into that community and get a better understanding of the needs and concerns for that community. Thank you.
Thank you, Ms. Peggy. And Troy.
Well, they stole my answers. Building the coalition first, Peggy, you're spot on, right? And being comfortable with the quiet in a room and letting space for that. Dr. Glenn, you're spot on, right? Like, it's all about leaving that opportunity for them to speak. And a lot of times you got to remember your privilege and your power in those conversations. Even if you come from a community that is also underserved, that doesn't mean that in that room, you aren't the one with the privilege or you aren't the one with the power. The other piece, I'll have one that's odd. So citations and stories are my big things. Being able to cite and talk to them from people within their community that have written great books, published great articles, talked through the data with them. Being able to do that is really important. And having a story that shows your vulnerability often allows space for people to show their own vulnerability. So those would be mine.
I have no words for how incredible this entire conversation has been. So we're just going to give a second for us to be taken off of live streaming. We will unpin the speakers and open up to a little bit of offline conversation.